Well, there's no question that the opioid epidemic is evolving. And so now we have most of our overdose deaths from heroin and fentanyl. And those deaths, unfortunately, are increasing. But we do know that there are strategies in place to address some of these issues. We have more focus on treatment, which is really what we need right now. We need to make sure that those folks who have an opioid use disorder, who have an addiction, have access to treatment. When you talk about reevaluation of the options and alternatives to treat pain, that requires everyone. So again, we have to make sure that insurers pay for those alternatives. For instance, physical therapy may be helpful, but does a patient have access to that if it's an increased copay for physical therapy versus one prescription? And what about paid time off? So doctors are certainly and have always been willing to make treatment recommendations, but it's important to make sure that those alternatives are available. So I think we have everyone from the FDA looking at this. People are looking at maybe non-addictive alternatives to treat pain. I can tell you that I am a part of a task force at NIH where there's a whole research paradigm going forward looking at alternatives to treat pain. So everyone is working together to make sure that there are alternatives to treat pain. However, we want to make sure that those who are doing well, taking their meds as prescribed, and have never misused their opioid prescription, still have access to that medication. So every state has a registry, and each state has a different law, but for the most part, this is a database. So let me just say, as a physician, I prescribe an opioid. I first of all go in and check that database to see if anyone else has prescribed another opioid recently or a medication where there may be a negative side effect from that. So it really is a tool in the toolbox for physicians, and so that is kept in a database, and physicians again can check it to see what other medications a patient's on and to see if there might be a need to have a discussion with the patient. One of the things we have to be careful of regarding this database or anything else is that we don't judge and that we have conversations with the patient. So these databases really are alternatives. I see that you're on an anti-anxiety medication and you're also on this opioid medication. Let's talk about the fact that that could be a deadly combination. So these databases are important, but they're not a panacea. And I will also say that we want to make sure that these databases are kept in public health department. Again, these databases should be used as a tool to help our patients. You also mentioned about a national database, and so what's very important is that there already is an agency, the National Association of Boards of Pharmacy, that can link, I believe, 48 of the states already. So if I'm here in Georgia and I'm practicing maybe near the border, I can have access, if that state has decided to participate in that, to information around Georgia, Florida and Kentucky and so forth. I have to say these databases are just for controlled substances. So each state might have a different list of medications, but mainly it's about either opioids or about benzodiazepines. So mainly controlled substances in that particular database. Alcohol and opioids do not mix, but let's just take this back a step. It's important to have conversations about risk factors for a substance use disorder as a general part of our practices. And particularly, again, when prescribing an opioid. And the AMA is encouraging physicians to do a risk assessment, again, including past history of problems with other drugs, medications, misusing other medications. So that's a part of the overall evaluation and questions that physicians ask before they prescribe an opioid. So again, we really need more research to make sure that we can offer evidence-based alternatives to pain. Everyone may think they have a good idea, but really these ideas have to be studied, and of course that's what we do as physicians regarding evidence-based treatment. But here are some right now. We know that some folks are relieved by physical therapy. But you know what? A surgery might be an option. We have pain specialists who offer nerve blocks. So there could be interventional alternatives. There could be other medications that work that are non-opioids. It could be biofeedback, again, physical therapy. And so all of these alternatives are available now. It's important that we have a research agenda, again, from the national perspective, to identify additional alternatives, non-opioid alternatives. But again, even if an alternative exists today, if a patient cannot afford it, either because they have a high copay, or it requires more time off from work, or they don't have any insurance at all, then we really have not provided the access, and we really have to work on that.